What I'd like to do is just give a brief talk as well, um, just about looking back into the past of COVID. And for those of you who just joined, my name is Dr. Kumran Govender, and I'm a researcher and infectious disease clinician at the University of Oxford. And so thanks very much to Darent for inviting me as well to this forum. So the topic today was really looking into the future. And to do that, we need to look back into the past to see where we've come and how much we've achieved and where we went wrong. And what I would like to do is just highlight the achievements we've made in the past 2 years since COVID was discovered, and also the problems that we ran into. And so I think for the last 3 years, the most three important technological developments that we've seen has been, number one, has been the development of vaccines. That has really, really changed the landscape of the pandemic. And adding on to that, there's the issue of access. So who can access these vaccines? And we've seen the issue of vaccine access, vaccine inequality, and even vaccine apartheid, where rich countries tend to hoard vaccines and poorer countries tend not to procure the vaccines needed for their population. And what this results in, this can result in new mutations forming as well and new variants forming. And to give you an example, so right now, over 50% of the world is actually fully vaccinated. But if you look at the continent of Africa, for instance, less than 5% of people in Africa have been vaccinated on average. Now that is shocking, that is a shocking figure. And as you can see in certain countries, like for instance, Canada, if you remember, Canada procured 9 doses of vaccines for one citizen, for every citizen in the country, when people around the world could not get any vaccine. So I think really this is a global problem, and it's a problem that we all need to work together to solve, and there needs to be a cooperation across multiple governments. So the other most important technological development, I would say, is also PCR testing and also rapid antigen testing. And so for the first time, we're really getting this rapid diagnostic testing done in the midst of a pandemic. So we really can understand the pandemic, we can understand the patterns, and we can understand different waves. And we've never had this amount of data in dealing with previous pandemics. So that has really revolutionized a lot of the pandemic. And then also, I would say the new treatments that are coming through. So we know steroids are effective. We know there's new monoclonal antibodies, for instance, that can be used. Again, there's an access issue, but there's lots of research being done where it's the first time in any pandemic that we've researched novel treatments to be used within the pandemic. And so that's really a success. But also talking about novel treatments, it also ties in with misinformation. And I'm sure many of you would have seen messages through mobile phones and through Facebook or WhatsApp Messenger about medications that said to work, but perhaps are not evidence-based. And we've seen many of those. We've seen medicines like azithromycin, for instance, ivermectin, a lot of these medicines being recommended by many people around the world that are not based on scientific evidence, and that has been a real problem as well. So I would ask, what has been the most 3 critical mistakes we've made in the COVID-19 response since the pandemic started? And I think the first mistake that the world has made is misunderstanding the concept of herd immunity by natural infection. And that really means that we are overestimated herd immunity helping us. And this is because of multiple factors. So there was a model where we isolate the vulnerable and then allow the less vulnerable to actually develop immunity. But factors such as close living together with elderly people and people in the community results in spread anyway. And then we had no idea at the stage of new variants appearing as well. So because of new variants, it lowered the threshold for herd immunity as well. So there would be viral escape. And so the whole concept of lockdown and governments at that time to take a decision to lockdown was very, very important. And you can see countries like Sweden, for instance, who took the approach of herd immunity, quickly learned from their mistakes, and then they've learned from their mistakes and moved on. So I would say the next critical mistake as well is not knowing or thinking about variants. It took us well over just a year before new variants were identified. And I think it speaks to the problem as well of there being surveillance systems in countries all over the world to pick up new variants, to pick up new infections as well. And that's something that really needs to be built. It needs to be part of robust public healthcare systems. And in the poorest of the poor countries, that is where infections don't get picked up, where new variants don't get picked up, and we have no data on that. And so that's really, really a big problem. And I would say the other crucial mistake has been vaccine nationalism. And so that's really hoarding vaccines, because I think really if we share vaccines, and I'm talking about from country to country, I think there's the chance of less variants being spread is much better. And so really, where you have uncontrolled COVID cases, where you have numbers that are really high and uncontrolled viral spread, that is where we see lots of mutations in the virus, which can lead to new variants that may spread in the world. And so moving along, what would be the three most underestimated challenges in COVID? And I think right now, one of the biggest challenges we face going on into the future, and this also with the new variant Omicron, is really the growing problem of long COVID. So we know we have preliminary data to show that 10 to 30% of patients who are infected with COVID go on to have clinical symptoms that we call as long COVID. And this can be described as brain fog, where people describe they can't think properly. Sometimes many people describe it as intense fatigue or shortness of breath or lack of smell. And this is after the COVID infection has persisted and or has completed. And so that's really a big problem. And there's still lots of data coming in about that. And so that really speaks still to measures currently, including using mandates such as face masks, social distancing, etc., to stop the spread of COVID, even if it's variants that are less mild or less severe compared to Delta and Beta, for instance. And then the other big challenge with COVID-19 that we face going on to the future, I think, is also about waning immunity, vaccines, and variants. And this is really what I'm talking about, is the challenge of vaccine protection, because once we do take a vaccine, the protection we get only lasts for 6 months. And then we need to take a booster. And so what happens is, as you have new variants and mutations, we don't know if there will be something called immune escape or vaccine escape. And that's really when vaccines no longer work. And I can give you an example. For instance, the AstraZeneca vaccine that was developed here in Oxford, for instance, worked really well in the United Kingdom. It was over 80% efficacious. But then when it was trialed in South Africa, when the Beta variant was in circulation, it performed really, really poor. It was about 30% or so efficacious. And then so you could see, for instance, how that poses a huge problem of protecting people. And so I think that's one of the challenges going forward, is really to keep up with vaccinations as well, developing new vaccines, especially if the virus becomes endemic and part of the seasonal changes that we see. So yeah, I think in summary, I think we need to recognize our interdependence, and we really need to fight pandemics together, because humanity needs to create a united front against this global threat. And those are the words that I'd like to say. So I'd like to call upon our next speaker to the panel, and this will be Dr. Aravindan Selvaraj. So Dr. Aravindan Selvaraj.
You got me. Yeah.
Yes. So Dr. Aravindan Selvaraj is the co-founder and executive director of Kauvery Hospitals and is the Chief Orthopaedic Surgeon at the Department of Orthopaedics. He spent his 15 years in Ireland and the UK to hone his skills in working in renowned hospitals like King's College Hospital and St. Thomas Hospital, London. With an intention to improve the health facilities in his motherland, he co-founded Kauvery Hospital in Chennai, which has been expanded to a more than 1,500 bed hospital at present, with its presence in multiple cities around South India. He's a recipient of several awards for his outstanding work, including the Best Orthopaedic Prize and Best Doctor by Tamil Nadu Dr. MGR Medical University and Pride of Tamil Nadu 2018. Dr. Selvaraj.
Thank you, Dr. Kumaran, for the lovely introduction. And I thank the DPF coordinators, executive coordinators, Mr. Darnidharan and Pugal Gandhi for giving me this opportunity. See, the one thing is that the COVID, even at a personal level, is a once in a 100-year opportunity to learn from the lessons. What we did good, what could have been better, or how can we face the future if there is a pandemic, God forbid, in future. And since I had my clinical experience for 15 years in London, and back in southern Indian state of Tamil Nadu, and I manage a private healthcare institution. So what I can speak, this is since the topic is mostly about the public health policy. I had a few observations how India as a country can do better learning from the lessons from the pandemic. I want to see it as in three phases. One is the pre-pandemic, second is during the pandemic, and third is in the post-pandemic. The pre-pandemic, and also most of my observations or suggestions will be related to the developing countries. So, I mean, the one is we had excellent views from Dr. Kumaran and Dr. Dhanapal about what is happening in the developed countries, UK, Singapore, and all. But let me limit my observations to a developing country like India. The pre-pandemic, yes, though the pandemic was right on the face, the impending pandemic was right on the face in December 2019 itself, I think the government, government or the society did not heed to the pre-warnings. And until the second week of March 2020, we were all in denial. And come third week of March 2020, then the whole country went into an unprecedented lockdown with the 24 hours notice, causing insurmountable hardship to the people, particularly in a country like India where there's no social support or social network. So this, I think, though the pandemic was evident facing on us, but we refused to accept that the pandemic is going to come to India. This I attribute to the lack of scientific temperament generally in the society, and which translates into the decision makers in the government as well. So we could have done a lot better by anticipating the pandemic and preparing the people, particularly the underprivileged who don't have any support systems, or prepare themselves for the lockdown and the economic fallout because of that. So that is one lesson, the pre-pandemic, that we have to take it in mind when people develop public policies, particularly for the developing country like India. And during the pandemic, what happened during the pandemic is we went in for a lockdown in this first 3 weeks and 4 weeks, thinking that a lockdown will be the solution. But at the same time, there's a lot of pseudosciences also which came into play. See, the people at the policy-making power, the decision-making power on behalf of 1/6 of the population of the world, that they've got a much larger responsibility to promote what is the scientific evidence, and based on that, this public health policies should be developed. Whereas here we face a situation where the people started believing in pseudosciences, or the sciences which is based on not evidence. Like people started believing that lighting of lamps or banging of vessels will cure the COVID, or a particular people of a particular faith were responsible for the spread of this pandemic. So that is because of the lack of scientific temperament in the society in a developing country like ours, which played a havoc in the spread of the disease and later on the secondary effects of that. So this, as we all belong to professionals, and then the scientific professionals, the medical professionals. Then the onus was left on the medical professionals to spread what is really science, what is a pandemic, how does it happen, right? What are the methods we can handle the pandemic or prevent the diseases? So there was a huge burden on the medical frontline workers like us. On one hand, you deal with the sick patients. On the other hand, you deal with the beliefs based on pseudosciences. So the onus became a responsibility of the professionals to deal with it rather than on the people who are making the policies. That was a huge, huge challenge for us in India. We could have done a lot better on that. Then as they started, when the pseudosciences fell apart, the public and the government came back to the scientific community. Then only the scientific community got involved. And also how the things during the pandemic, the particular Dr. Elilan very eloquently addressed about how Tamil Nadu as a state fared better, because Tamil Nadu for the past 40-50 years have been spending a lot of money of their GDP, the public expenditure, on developing the public health infrastructure, whether it is primary healthcare or the secondary and tertiary healthcare, or development of the medical colleges, development of producing more number of medical graduates. Tamil Nadu and Kerala did a wonderful job. But that is not the case across the Union of India. So on one side, we were fighting the pandemic. At the same time, we had to, the doctors, including myself, we were educating the people about what is the real science about. And one challenge we had was of the remdesivir, right? The remdesivir. People were queuing up, people with the drips, IV lines in their hands, queuing up in government hospitals or government supply centers to get the remdesivir. And then later on, WHO came out and said that remdesivir is not the solution. It does not have any evidence. So these kind of evidence-based medicine could not be propagated, though it was suggested by the medical community, because lack of support for the scientific evidence from the people in the government. See, and then the post-pandemic, right? I mean, a pandemic is not over yet, but we all have to prepare for the post-pandemic public health policy making. As Dr. Elilan mentioned, we are in a very strange situation, right? Even Mr. Darnidharan, I mentioned, the Executive Co-ordinator of the DPF. India is the only country in the world, probably, which has cut down on the health budget in this year where the pandemic still rages. In relative terms, there's a moderate increase in the healthcare spending. But what has happened is this healthcare spending has been combined with the social sectors like water and sanitation. And also, if you take the factor of inflation into account, actually the healthcare budget this year has been cut down. How is it acceptable? See, when we are still dealing with the pandemic and we have to prepare ourselves for the post-pandemic sequelae, but India as a developing country has, the percentage of the GDP wise, we are spending only 2.5% of the GDP on the healthcare, whereas United States and the United Kingdom spend more than 15% of the GDP and the healthcare. So there's a huge challenge ahead. I mean, I have a fear that all the people in power will take us pandemic as a one-off an episode, don't learn any lessons from this, and move on with the next assignment. But that is not good for the health of the society, health of the nation. And our Honorable Finance Minister of Tamil Nadu always talks about the federalism, and then here we have earned a huge data from delivering this healthcare during the pandemic times. But if you ask me whether the state government has got access to all this health data, I don't think so. Right? The data is centralized, but the data has to be localized. There's data, my health, my data, my people, my society is my data. It has to be available for me as a person in decision making to deliver what is best for my people. But data again is centralized, which is not being shared with the states. So with this kind of approach, where this centralized control, for example, the vaccine procurement, vaccine availability, whom to be given a vaccine, not to be. See, all this, the control is at the union level, whereas the impact, the fallout, the ill effects is borne by the state and the people. So there has to be, particularly for a country like India, which is so diverse, contributing 1/6 of the humanity, there has to be control at the local level. The states like Tamil Nadu and Kerala, which have been doing very well in the public health infrastructure or education, have to be rewarded rather than being punished. So this is my taking. I mean, as an individual, as a practicing professional, or even as a family level, I tell that this is, one thing is, though there's enormous suffering from the pandemic, this is a once in a 100-year opportunity to learn what we can do better, pre-pandemic, during pandemic, or post-pandemic, from the public health policy perspective. But if we fail to learn the lessons, it is really very sorry state of affairs. And then I hope the scientific temperament prevails upon the people who make the decisions, and then we can all have a better and equitable world. Thank you.
Thank you. Thank you so much, sir. And Kumaran, you can go ahead.
Yeah, thank you so much, Dr. Selvaraj. Appreciate the insight into the Tamil Nadu workings as well. That was really helpful in understanding that.